We are live, huh?
Yeah.
One moment.
Like how we kept the tap on the book yesterday, no? We keep the tap on them also. We want to first for 2 days, we want to cap it to 30 KYC, 50 KYC in a day. Understand that
We are live.
Shall I start now? Good evening, everyone. So today, for the second of the webinar series on kidney transplantation in children, I welcome you all to this webinar session. And I will introduce the chairpersons and the speaker to everyone. Then there will be the talk on ABMR. After that, we'll have some small discussion. And after that, there will be case presentation. And after that, we'll take questions from the audience. So let us start with a tribute to our founding father of IDKRC, Professor late Dr. H.L. Trivedi. Let me introduce our chairpersons today, Professor Dinesh Gera. He has done MBBS and MD Pediatrics from BJ Medical College, Ahmedabad. After that, he did his DM in nephrology. And he has been the professor and head of pediatric nephrology at IKD since 2008 and has trained more than 35 DM nephrology students under his mentorship. And he has multiple publications to his credit. Other chairperson is Professor Pankaj Shah. He was also at IKDRC for a long time. He has been the former dean and head of the department nephrology at IKDRC Ahmedabad. Currently, he is a senior consultant nephrology and transplantation at Selby Hospital, Ahmedabad. He has outstanding contribution to nephrology with over 40 years of experience and has overseen over 5,000 kidney transplants and has several publications to his credit. Professor Kamal Kanodia is head of the department pathology at IKD. He has done his MD pathology from MP Shah Medical College. After that, he did his PDCC from Indian College of Pathologists in 2004. He has 24 years of experience and has interest in renal and transplant pathology and has several publications to his credit. Now let me introduce our speaker, Professor Madam Dechu Pulianda. She is professor in pediatrics and pediatric nephrologist at Cesar Sinai Medical Center, California. She has done her MBBS from Mysore Medical College in India. Then she went to United States, did her residency at Rush Medical College in Chicago. She has done her fellowship in pediatric nephrology and renal transplantation at Harvard Medical School, Boston. She has interests, several various interests in viral infections, in renal transplantation, biomarkers for rejection, management of highly sensitized and treatment of ABMR, and also has several publications to her credit. So I will stop screen sharing now, and I will request Madam to start her talk. Madam Pulianda, please.
Thank you, Anshuman. Let me just screen share. Can you all see my screen?
Yes.
Yes.
Yeah, great. Good evening, everyone. It's always very heartening to see you all on a Friday evening when most people would be wanting to do something else, to actually come together to listen to science and then this topic that is, has been a challenge to a lot of us, antibody-mediated rejection. You all on a Friday evening. I'm not sure if there is a lag or only I'm hearing it, but I'm just going to keep continuing. Is that okay?
Yeah, we can hear clearly.
All right. So I I have a lot to cover today. I didn't realize.
Yeah.
Someone talking to me?
No,
Sorry.
no.
Okay,
Yeah.
let me keep going. So, I have a lot to talk to you today. The initial stuff I will do a little faster because a lot of you in the audience know about it already. I'll focus a lot on the pathophysiology and what we know about treatment aspects, and then talk a little bit about prevention. So, I always like to bring in this historic perspective. The first kidney transplant was done in 1954 between identical twins by Dr. Joseph Murray and colleagues in Boston. And this was a picture that I had the privilege of taking in the American Transplant Congress in 2004. We just finished another one day before yesterday, which we returned from. But in 2004, this was a very, very, surreal, exciting moment for me to capture the picture of not only the first surgeon who did the kidney transplant, but the first donor. So he gave his kidney to his twin brother in 1954, and he actually survived up until his 80s when he passed on. So, I like to show this picture to even donors, telling them that, donors do extremely well after transplant, after giving their kidney. And in a little more of a historic perspective, this is right, next door to us at UCLA, there was a 6-year-old patient. This is the first pediatric patient who was transplanted, who has done extremely well. And 50 years later, he's there with Dr. Richard Fine, still kind of doing very well with that same kidney, which is amazing because very few grafts last for this long, regardless of what we do. And even back then, when they didn't know very much, they had successful graft outcomes when they could. But despite remarkable advances made since 1954, leading to improved graft outcomes, long-term failure is still very, very high. We all can, when patients ask us, how long will the graft survive? We're able to say that in the first year of transplant, the short-term graft survival is over 95%. But, we all know that we can't keep these grafts working for an extremely long time. The 10-year graft survival rate is around 50% for deceased donors. The 10-year graft failure rate. So how many grafts fail in 10 years? 50% of the grafts for deceased donors fail in 10 years. And about 35% the grafts fail. They get it from living donors. And the 64% of this graft failure is attributed to rejection. And all these patients had chronic antibody-mediated rejection. So I just wanted to touch on different types of rejection. One of the first types we know is hyperacute rejection, which is related to preformed antibodies that in the past could not be kind of detected in a very reasonable way. These antibodies are like, I say it's like primed cells, policeman cells. As soon as they see that kidney, they just attack, destroy the transplanted organ within a few hours. But we rarely see it these days because we do DSA testing, very sensitive cross matches, TB flow and all that stuff prior to transplant. So hopefully we don't see much of the hyperacute rejection. And the histology, I always put a normal glomerulus to show you, and you can see that in hyperacute rejection it's completely full of thrombus, and the graft is rejecting. The next type of rejection that we saw for a number of years was what we know as T-cell mediated rejection. And it is, especially in the first few years of transplants, the most frequent rejection. And it's characterized by this lymphocytic infiltration of the tubules that we call tubulitis, and the interstitium, and sometimes the arterial intima. And it's usually treatable. And I think we all know that these T-cell mediated rejections can be nicely treated. And usually, again, does not lead to graft failure. However, when you have T-cell mediated rejection, which I've abbreviated TCMR, it may be associated with early graft chronicity and progressive renal dysfunction. So just another histology here. There's normal on the, on one side of the screen, and then T-cell mediated rejection, which you see, what I describe as a sea of dots. They're all lymphocytic infiltration in the tubules, in the interstitium, and sometimes in the arterial intima as well. So the one that we will focus on today is antibody-mediated rejection. abbreviated either AMR or ABMR. This is actually sort of the newest form of rejection, if you will, in the transplant world. It was introduced in 1997, which is not too long ago compared to when we first started doing kidney transplants. And it demonstrates evidence of circulating donor-specific alloantibodies, and those alloantibodies cause antibody-mediated injury to the kidney. In the simplest explanation, that's what it is. And it's the most important cause of allograft failure in kidney transplants. I always like to show this slide that shows that, the timeline of what happens with days post-transplant. So the days post-transplant is in the x-axis, and the probability of graft loss is on the y-axis. And you can see that, the red line representing T-cell mediated rejection happens within the first, is very prevalent in the first year after transplant. But antibody mediated rejection starts to take over, this dark blue line here. And, about, 3-4 years after transplantation, antibody mediated rejection seems to be the very pronounced, cause of allograft loss over here. So diagnostic criteria for antibody mediated rejection. First of all, up until now, the diagnostic criteria was limited to histologic diagnosis, but they're introducing more and more, parameters to that, in addition to histology, to be able to make the diagnosis of antibody mediated rejection. I just really need to acknowledge Dr. Kanodia, who's here, pathologist. And Dr. Kanodia, please, at the end of our talk, please chime in terms of any of the histology portions that are important that I may have missed. So in order to make the diagnosis of active AMR, you should have 3 criteria, and all 3 criteria must be met for diagnosis. Again, I must say that, the criteria is called BAMF criteria that we use, and it is in a process of evolution. We've had several iterations of the BAMF criteria. This is the most recent one that was published in 2020 in HAT, and it's the 2019 BAMF criteria. So, and again, each of the evolving BAMF criteria are sort of improvements over the previous one, obviously. So this is the most latest one. The histologic evidence has remained the same throughout in the BAMF criteria, where you have to have some sign of inflammation. So microvascular inflammation, arteritis, thrombotic microangiopathy, or acute tubular injury. But amongst all of them, microvascular inflammation has to be there to make the diagnosis of AMR. The second is the evidence of some kind of antibody interaction with the vascular endothelium. And this can be either with C4D staining of the peritubular capillaries. It means, and I'll show you in the successive slides why you need to have that, why C4D staining happens when antibody interacts with the endothelium and recruits complement. You can have that complement staining of the endothelium, that's linear C4D. Also, moderate microvascular inflammation qualifies for that. And the most recent BAMF criteria talks about increased expression of gene transcripts in the biopsy. Most centers are actually not doing it as yet because you need another tissue when you do your biopsy, and that tissue needs to be subjected for gene transcripts, but that has been included in the most recent BAMF criteria. And the third is serologic evidence of donor-specific antibodies, either HLA antibodies or non-HLA antibodies. And even C4D staining counts or expression of transcripts. So basically, 1 and 2 are kind of the most important. The 3, the serologic evidence actually encompasses the 1 and 2 criteria. So I just wanted to show you some quick pictures here. So again, when you see blue dots, that's always the sign of inflammation because it's lymphocytic infiltrate. And you can see here, this is a peritubular capillary, and you have a lot of blue dots here. So it's peritubular capillaritis. And then glomerulitis is also represented by these blue dots in the glomerulus, and the focal C4D staining in peritubular capillaries. This is diagnostic for AMR. And like I said before, the microvascular inflammation, which is the peritubular capillaritis, is a hallmark of AMR. And then C4D. So there is another entity called chronic AMR. So we talked about active AMR, but when active AMR persists, you can get into a stage where the AMR is actually chronic. So that includes criteria 2 and 3. So where you have to see some microvascular inflammation, you have to have some DSAs or C4D staining. But along with that, you actually have to have multi-layering of the glomerular basement membrane. It's like repeated injury causes the glomerular basement membrane to keep layering itself. So that multi-layering of the glomerular basement membrane is what qualifies for chronic. Again, wanted to show you a quick picture here. You can see on this glomerulus, you can see that there are several layers or rings around the capillaries that signifies the multi-layering that we see. And on electron micrographs too, you can see the multi-layering of the glomerular basement membrane. And arterial and arteriolar intimal fibrosis. So this, the one below here is arterial and arteriolar intimal fibrosis, also is a hallmark of chronic AMR. Again, this is the reduplication of the glomerular basement membrane, which is shown by the arrows here. That is also the hallmark of chronic AMR. So let's get into the pathogenesis. If you read multiple books, immunology and stuff like that, it gets to be extremely confusing. And I'm going to show you one slide that, the doyens of, immunology put together as to what they believe may be the pathogenesis. But I have a very simple mind, and I have to kind of bring it down to something that I can understand. And if I can understand it, I'm hoping that you can understand it too. So this is the really sort of, for want of a better word, dumbed down version of the pathogenesis, where you have recognition of the donor antigens. So donor specific antigens are recognized by the recipient's T cells, specifically the T follicular cells. And this causes the activation of B cells. The B cells differentiate into plasma cells, and with the help of IL-6, produce large quantities of antibodies that we call donor-specific antibodies. So I'm going to come back to this slide when I talk about treatment, because it'll help you understand, why we use certain drugs in AMR. But basically, you have to understand that there are antigens when the kidney is implanted in the recipient, and these antigens are recognized by T cells. They crosstalk and they activate B cells. B cells differentiate into plasma cells. And with the help of this cytokine called IL-6, they produce large quantities of antibodies, which can be injurious to the graft. Okay. All right. So let's talk about these antibodies for a minute. So these antibodies can be directed against donor HLA antigens that are in the allograft, or they can be directed against donor non-HLA antigens. And we're beginning to recognize a lot of the non-donor HLA antigens. So when they're directed against donor HLA antigens, what happens is these antibodies that are directed against the donor HLA antigens can recruit complement, or they're called complement fixing. So not all donor-specific antibodies are complement fixing. The more pathogenic ones are complement fixing. So they recruit complement and they cause injury to the graft. And then there are the others that can cause injury without even fixing complement. So you have two types of the donor-specific antigens. In terms, again, about the non-HLA antigens, the one that we know of most predominantly is angiotensin 2 type 1 receptor antibodies. But there are others like they call MIC-A, Vimentin. I just got back from the American Transplant Congress 2 days ago, and my God, like the number of donor non-HLA antigens is just increasing. Everybody's looking at specific targets, and I'm sure, they're important in one way or the other. Okay, so let's talk about the specific DSAs to HLA antigens. So I told you the mechanisms by which they cause injury can be complement dependent. So they can recruit complement and cause injury, but they can also cause direct endothelial injury, and they can cause injury with antibody dependent cellular cytotoxicity. So the most important way it causes injury is complement dependent cytotoxicity. Here's a very nice picture that I found showing DSA mediated injury. So in the beginning, you'll see that these antibodies are also called C1q antibodies, complement fixing antibodies. What happens is the DSAs recruit these complements and then they cause injury to the graft. And when they do that, that's when you'll find C4d. Okay, so when you find C4d staining, it means that the DSAs are more than likely complement fixing, and that's how they're causing injury to the graft. But you can have injury to the graft in two other ways as well. One is they can cause direct endothelial injury to the graft. So just directly attack the endothelial cells, the HLA and antibodies, or they can cause antibody-dependent cell-mediated cytotoxicity, which means that these DSAs recruit these cells, macrophages, neutrophils, NK cells, and they all cause injury to the graft. Now you can actually see in this slide itself why you can actually have AMR without positive linear C4d staining, because there are certain DSAs that can cause injury in non-complement dependent ways as well. Okay. All right. So there are some clinical phenotypes of AMR. So AMR is not all the same. Okay. There is AMR that occurs in different times post-transplant, and these types can be pretty, different. And, so the 2019 Transplantation Society divided these AMRs into 3 different types. The first one was the early post-transplant active AMR, which we hardly see. At our center, we do a lot of highly sensitized patients. So highly sensitized patients can actually have AMR within the first month. And then the other 2 are the late AMRs. So late means more than 30 days post-transplant. And that usually is one of the kinds is that with pre-existing DSAs, again, this is something we see in the highly sensitized patients who have preformed DSAs, and they have late AMRs after 30 days. But the most common AMR that all of us see in our transplant patients is AMRs that occur later, but with de novo DSAs. And these are the hardest ones to actually treat, in my opinion. Okay. So, a lot of the AMR that you all are seeing, and, what we see as well is the AMRs that are late, more than 30 days post-transplant, associated with de novo DSAs. So quickly, early post-transplant AMR, there's an abrupt allograft dysfunction in these patients. It's usually C4d positive, and you can find DSAs against HLA class 1 or class 2. Fortunately, when you have early, so less than 30 days, you can treat them, and, the allograft function can be restored, and all the histological changes can be completely resolved. This is sort of the, if for want of a better word, a best type of clinical phenotype of AMR to actually have. And the other 2 are after 30 days post-transplant. And then this progresses very slowly. There's some allograft dysfunction, but not quite. It's commonly identified on surveillance biopsy, either for cause of a minor allograft dysfunction. And depending on the timing of the biopsy, you can have subclinical, active, or chronic AMR that is diagnosed. And although the allograft biopsy shows subclinical AMR, you can proceed to transplant glomerulopathy or allograft failure. So when they looked at these AMRs, those with de novo DSAs were diagnosed at about 4 years after transplantation. But those with pre-existing DSAs, the ones that are highly sensitized patients going into transplant, for them it was diagnosed earlier. So again, what we are seeing most commonly is the AMR that's diagnosed with de novo DSAs, and it's usually about 3 to 4 years after transplantation. Okay, so what are the predictors of poor outcome when you see such AMRs? De novo DSA is the independent risk factors for formation of de novo DSAs are, as you know, non-adherence. And in our, again, in the pediatric population, reduction of immunosuppression secondary to either leukopenia, viral infections, or intolerance to medication. So sort of iatrogenic reduction of immunosuppression for good reason, but these lead to de novo DSAs. If you have a cellular rejection, it can go on to get you antibody-mediated rejection. They say young age, but I think that young age also is because more prone to viral infections and reduction of immunosuppression, disease donor transplants, and HLA mismatch, especially DQ. So after de novo DSA formation, it's been said that graft loss occurs in about 24% of allografts in 3 years. So that's a, pretty, strong number, to have 24%, 1/4 of your grafts lost within 3 years after de novo DSA. So let's come to treatments. Before I even start, I must say that all of these treatments are in a process of flux. We do not have a specific treatment for AMR, just like we do for TCMR. For TCMR, you have like pulse steroids, and maybe if it's BAF1B, you'll probably give them thymoglobulin or something higher. You can, have complete resolution of the TCMR, but we have not had such gratifying treatments for AMR, and I can only tell you what has been done, in terms of AMR treatments. So again, most studies small, heterogeneous, retrospective, no approved effective treatments, and no personalized treatment approach. So regardless of whether you are an early AMR, a late AMR with preformed DSAs, or a late AMR with a de novo DSA, and regardless of whether you have chronic active or just active AMR, we treat everyone the same. And that's one of the problems in looking at treatment outcomes. But regardless, let's talk about that. So this is definitely the major challenge in the field of transplant. Before I go into treatments, I always like to introduce this little slide to you: the MABs, the MIBs, the NIBs, and the NABs of medications. So MABs stand for monoclonal antibodies. So if you see a name and people are saying that they're using that drug and it ends with the MAB, it stands for monoclonal antibody. The MIBs are proteasome inhibitors. Bortezomib would be one of the drugs in that class. And then the NIBs are really small molecules that are inhibitors of kinase enzymes, okay? And then there are also these NABs that we don't use in transplant, but you might hear it in the rheumatology world. It's a nanoparticle that's albumin bound. So there's a reason why these names are given, because they actually represent what they are. And of course, we all know that anything that ends with ACE is an enzyme. And then they also differentiate between the chimeric and the humanized. So chimera always has an XI in it. So rituximab, when you hear the name itself, it's not all humanized. It's a chimeric antibody. And if it ends with a Z, so ZU, or it has a Z or a ZU in the middle, it's all humanized. So, the nomenclature is so interesting. I thought I'd share that with you. So this is the slide that, all the brains of transplant immunology put together in terms of therapeutic approaches to antibody-mediated rejection. A very look at this slide just, gave me a massive headache. So I had to break it down into something that was reasonable for me to know. So we're going back to that slide that I showed you on the pathogenesis of AMR, which is, the donor antigens are recognized by the T cells, there's activation of B cells, they differentiate into plasma cells, and with the help of IL-6, produce large quantities of antibodies, which can recruit complement and cause allograft injury, okay? So based on this pathogenesis, the treatment options are, so we'll start with, how do we prevent the donor antigens from being recognized by T cells? You can give a number of drugs, anti-thymocyte globulin, methylprednisone pulse. We use tacrolimus and sirolimus, and belatacept has also been found because it's a co-stimulatory inhibitor, so it can decrease the recognition of the donor antigens by the T cells. How do we prevent activation of B cells? We have several B cell monoclonal antibodies. Rituximab, again, XI stands for chimeric. And then the cousins of rituximab, which is ofatumumab and obinutuzumab, which I hear are actually available in India. So to prevent the differentiation into plasma cells, a lot of centers are using bortezomib. If there are specific questions about it, we can talk. But for the sake of time, I'm kind of going to keep going. We've learned a lot about IL-6 cytokine as being a big helper to produce antibodies. So IL-6 inhibitors, either the receptor inhibitors or IL-6 inhibitors, the prototype of that drug is tocilizumab that a lot of you are using as well. And then if you want to remove large quantities of antibodies, you can do plasmapheresis. IVIG is used in all AMR protocols because they attack the antibodies that cause destruction of the graft. The newest kid on the block is this drug called imlifidase or IDIS, and I'll talk a little bit about it because we will be seeing it more in transplant medicine. And then to inhibit complement activation, you can use eculizumab or a C1 esterase inhibitor, which is also called Berinert over here. So they're all complement inhibitors. And with that, we hope to really prevent allograft injury. So we have a lot of treatment options, each targeting different sites of the pathogenesis. And to me, this is sort of the most important slide in my whole talk, because it actually tells you why you use each drug and all the results that we're getting with that. So going to IDIS. IDIS stands for immunoglobulin G degrading enzyme of Streptococcus pyogenes. It's a long name, but basically it's an enzyme that's made by Streptococcus that actually cleaves the IgG molecule. So you have, if you remember back when we learned, probably in medical college, the FAB and the FC fragments. So it just cleaves it at the junction, at the hinge region of the FAB and the FC region, and renders an antibody completely inactive. It's such a simple mechanism, and it's amazing how they actually discovered this. So when you actually give IDIS to a patient who has a lot of preformed antibodies, and you look at their antibody levels, you can see that on the top, represented in blue, is after 6 hours of treatment. And if you look at it just an hour after giving IDIS, there's absolutely no antibodies compared to the red that it was before treatment. So what we do now are a combination of treatments. And I can tell you what we do at our center. Different centers have different protocols. But really, the standard of care in most centers as sort of the first line therapy for AMR is plasmapheresis to remove antibodies, IVIG to soak up the antibodies that are still remaining, and then rituximab to prevent the formation of more antibodies, and antibodies all causing injury to the graft. And depending on which center you are, they use bortezomib. Actually, there's a very nice clinical trial that's coming out with bortezomib, so we'll see what the results of that trial show. It's bortezomib and belatacept for AMR, and then anti-thymocyte globulin, pulse steroids, and we've been using also this drug called tocilizumab when they fail plasmapheresis, IVIG, and rituximab. So use of the tocilizumab led to our paper showing the highest number of patients that have been treated with tocilizumab for refractory AMR. So they've been refractory to IVIG and rituximab, and in those patients on biopsy, they had ongoing AMR, and all these patients were treated with tocilizumab. This paper is actually, I wrote accepted, but we found out day before yesterday that it's actually in print. So you can, access this paper if you want to know like dosages, but I'm always available if you want to brainstorm with me. I just want to show you quickly the results of that trial as well. So, what we saw was that if you start, tocilizumab early in the course of the, early in the clinical course, when their GFRs are not too bad, these patients actually maintain their GFRs for prolonged periods of time. Remember, we talked about 24% of the patients losing their grafts once they have de novo DSA. What we found that these patients maintain their grafts for several years. The longest follow-up we have is 8 years in a patient who's been on tocilizumab, whose creatinine is still 1.1. But when you start a little later, like when damage has already been done, it's very hard to see any resolution, and a lot of these patients end up with dialysis, and you can see the red cross here represents the patient who had allograft loss. We separated them into those that had AMR and those that had mixed rejection, which is acute cellular rejection or TCMR, and we saw that there was no difference in their outcomes. They all were able to maintain their eGFR. We also looked at biopsy findings because, again, biopsy is the gold standard for making the diagnosis of AMR. And we looked at the biopsy findings before the start of tocilizumab and 6 months to 1 year after treatment. And what we saw was that even though the C4D staining completely, gets abrogated, it's like C4D staining gets really better, and we didn't see a huge improvement in the transplant glomerulopathy. There was a slight increase, but what we did see, despite these histological findings, is that they all had stabilization of the GFR, which is probably one of the most important things that we're looking for. So we had a decrease in C4D, we had a decrease in the the microvascular inflammation with peritubular capillaritis, but we did not see a decrease in transplant glomerulopathy. So the injury was kind of leading to transplant glomerulopathy. So in conclusion, the administration of tocilizumab in severe AMR refractory to B-cell therapy stabilized AMR, resulting in the preservation of renal function in most pediatric renal transplant patients. So that was the conclusion of our study, and we have a lot more patients on tocilizumab at this time here. So then, because the treatments are so, they don't cause complete resolution, what can we do? I think the best approach right now is something that we all try to do anyway, is prevention of chronic AMR. So preventing formation of de novo DSAs, improving adherence, we always beg them to take their medications, cautious minimization of immunosuppression for leukopenia, viral infections, and side effects. These days, what we're doing is, if we see a patient who has CMV, viremia, EBV, or polyoma, we try to use IVIG as we're reducing immunosuppression, because we feel that IVIG is an immunomodulator and it'll prevent formation of DSAs as you're reducing immunosuppression in order to take care of these viral infections. And IVIG, as you know, also has viral antibodies, passive antibodies that can help treat these infections as well. And then, of course, everybody talks about limiting mismatch of donor recipient with organ shortage. We need to find a better way to do that. We also think that, ischemia reperfusion injury can cause formation of DSAs because of injury to the graft. And so preventing that from happening is important. And then early detection and successful treatment of cellular rejection, because that gives rise to formation of DSAs. So in terms of that, this is the last part of my talk, where I really want to talk about monitoring the renal allograft, because till to date, all we had in terms of looking at sort of the health of the allograft was the serum creatinine and maybe proteinuria. But, there are so many biomarkers that are coming about and, helping us identify early rejection before we see a rise in the serum creatinine. We know that you can do a biopsy to look for any injury to the allograft. It's still the gold standard, but we know it's invasive and, it can have a low yield because of sampling error. So in addition to the biopsy, looking at just histology, adding these MMDX, the molecular classifiers, to look for gene transcripts increases the yield in terms of AMR. Again, this is the next thing that's going to come about for all of us to be doing in order to make the diagnosis of AMR. The next thing is DSA monitoring. And, I think a lot of centers do it. It's expensive. DSAs are all not created equal. Some are complement fixing, some are not, some cause injuries, some don't. So it's hard to know which of these DSAs is actually very important. But obviously, if you have DSAs and, if you have AMR on biopsy, obviously these are DSAs that are actually injurious to the graft. Sometimes you can have DSAs and, you do a biopsy and the biopsy looks pretty fine. So there are certain DSAs that may not cause as bad an injury to the graft. And then quantifying these DSAs in terms of fluorescent intensity titers and complement fixing, will give you a better understanding of how bad these DSAs are. Then we go on to the field of biomarkers. So an ideal biomarker should be non-invasive. So it shouldn't need a biopsy to actually, look for that biomarker. And it should be able to distinguish rejection from other diseases. And it should be also able to predict the prognosis of patients and grafts and risk stratify these patients as to who needs what kind of therapy. So I don't think we have too much in the way of that. Right now, we're only using the classic biomarkers, which is creatinine and proteinuria, but various biomarkers are in development at this time. Again, we started looking at this donor-derived cell-free DNA in early 2018. This led to our first publication in pediatric transplants, looking at donor-derived cell-free DNA. It's published, it's in pediatric transplantation. And we looked at 64 patients with, donor-derived cell-free DNA, and found that, the higher the levels of cell-free DNA, the much more likely they are to have rejection on biopsy. So our specificity was 100% and our sensitivity was 96% with the donor-derived cell-free DNA. Again, not going to go into that paper because it's published, and you're more than welcome to reach out with questions if you have any. But the other thing that's coming about is the gene expression profiling. We are going to be enrolling patients in a study starting August 1st on looking at this gene expression profiling, which is supposed to happen before even the biomarker elevation happens. So it tells you the sort of the health of the graft. We'll see how it actually comes about, but that's the study that we are going to be involved in soon. So one of the other questions that always comes up is, patients asking you, doctor, how long will my new kidney last? And it's so hard to predict what will happen. The group in Paris looked at a calculator called the iBox. And with that, they used a lot of parameters in the iBox, serum creatinine, proteinuria, some of the, the histology and all of that. And, kind of came to like the conclusion, or they could extrapolate how long their grafts will last. So here in the US, we do not have the ability to actually do only iBox, just like the France group does, but we're involved in a study called the Kidney Care in our pediatric patients, where we're looking at this donor-derived cell-free DNA, gene expression profiling, and adding it to that machine learning transplant data analytics in order to prognosticate how long the graft will last based on previous history of rejection, etc. So a lot coming up in the way of what we can do with our transplants and how we can keep it lasting longer. There are also some urinary biomarkers, but the best known urinary biomarkers are CXCL9 and CXCL10. To date, they're not able to very well predict AMR, but they're very good at predicting TCMR. Again, this is still in clinical trials. We need to learn a lot more about these biomarkers. So in conclusion, the definition of chronic active AMR continues to evolve, and therefore the diagnosis continues to evolve as well. It is no longer a histologic diagnosis, even though, Dr. Kanodia will be happy to note that we cannot not do histology in order to make the diagnosis. But along with histology, we have to incorporate like the clinical and the molecular entities as well. And in the future may include a lot of the biomarkers and, the iBox kind of data analytics in order to, prognosticate how long the graft will last. And there are no commonly accepted guidelines for treatment of AMR. So, but I think that any kind of clinical trial that we will do in AMR really needs to distinguish between the different clinical phenotypes of AMR, treating active AMR separate from treating chronic AMR, because we know that chronic AMR may not do so well with even any kind of good treatment, but active AMR, you may be able to reverse. So just well thought of clinical trials need to happen. And the development of donor-specific antibodies, we really need to prevent that as best as we can by very cautious lowering of immunosuppression and, of course, improving adherence in our patients. And all the treatments that I talked about are not without side effects. And therefore, you need to weigh the risk and benefits, because all of the treatments that I talked about, none of them completely reverse AMR. So, which treatment do you need to use in these patients? You really need to weigh the risk and benefits of all of these therapies that I talked about. And this seems to be maybe my last slide. I'm just really acknowledging the wonderful team that I work with over here. a phenomenal HLA laboratory, and we have a transplant immunology laboratory that works so closely with us. To all our renal pathologists, really here, we have some of the really world-class renal pathologists, Dr. Haas, and them, whom we always, talking to, and Dr. Jordan, who's my mentor, and of course, last but not the least, to all our patients who really allow us to do what we do, even though we don't have, all of the FDA-approved drugs or fully known clinical trials. Thank you so much. I do needlepoint, and this is my most favorite needlepoint, if you will, stitched on cloth, that I love to kind of show as my last slide as well. Thank you so much. Really appreciate it. I'm going to stop screen sharing, I think, and turf it over to Shanaz.
That was a wonderful talk, madam, very comprehensive and simplified. And now I invite our chairpersons for any comments or any questions, if they have.
I think Shanaz is screen sharing. Yeah, go ahead.
Hello, ma'am. Hello.
Yeah.
Hello,
Yes,
is
sir.
that
Please go ahead,
Dr.
sir.
Shah? Is
Yeah.
that Dr. Shah? Great.
Yeah, ma'am. Ma'am, good morning.
Good evening.
Ma'am, it was magnificent lecture and superb slides. No, I must appreciate.
Thank you.
Ma'am, I have one query. Oh, why you had experience with tocilizumab. While using tocilizumab, did you find increased incidence of opportunistic infections?
Very, very good question. We did find some infection, but the infections are much, much less compared to what you would see with just rituximab use or with the use of bortezomib. We had very few infections, and all of them were very easily controlled. We had BK viremia, and we detected that early, and we held the tocilizumab till the viremia got better, and then restarted tocilizumab after the viremia cleared. And the same thing with CMV viremia. So none of these patients had major infections that we had to actually hold off tocilizumab indefinitely.
Thank you, ma'am. Ma'am, have you personal experience of using imlifidase?
Yes. Our center is one of the major centers in the US that actually has used imlifidase. We have not used it for AMR. In fact, it's not available right now in the United States, but we are going to be involved in a clinical trial. But the times that we've used it is only for desensitization and at the time of transplant. We have not used it for AMR as the indication. But
my last question. Do you advise protocol biopsy to find out subclinical rejection?
That's a very, very good question. In our center, we do not do protocol biopsies unless they are in a clinical trial that needs a protocol biopsy. I think that centers that do protocol biopsy say that they get a lot of information, which I totally agree. But I really think that it's a fairly invasive procedure in these patients. And so if we can use biomarkers and, sort of biopsy only the patients who are at risk, maybe that may be the way to go. When they did a survey of all of the US pediatric centers as to what percentage does protocol biopsies, it was about 32% of US centers do protocol biopsies in children, and ours is not one of them. I still think it's a little invasive. It's not without complications, aneurysm formation, hematomas and such. So if we can find other ways to get to the early diagnosis of rejection, that might be better.
Thanks, ma'am. Thanks. Can we borrow your slides?
Of course, I can send it to Anshuman.
So nice of you, ma'am. So nice of you. Thanks.
Good evening. It's a very nice lecture, madam. And you have covered most of the things right from this pathology, histopathology and pathogenesis and treatment, which is very important, but you have given importance and correlation with the pathogenesis. Regarding this monitoring of the graph, he was telling about this biomarkers and especially gene expression and MMDX molecular classifiers. Actually, we don't have that much of facility in India and no validation center available here. So that's why we believe, or what we are doing, mainly dependent on the allograft biopsy.
Yeah.
Yeah.
Same thing with us, Yes, even here we have not started using MMDX because, like I said, it requires another piece of tissue, and the tissue needs to be on. We can't. The tissue needs to be immediately. You need to put RNAs later because the RNA gets degraded, and then you can't use that tissue, and it has to be sent immediately for analysis. So all of those things, I think it's going to be refined definitely in the next, hopefully several months to years. But I think that it will end up being as one of the important things that we look at on the histology, right, Dr. Kanodia?
And yes. And in our center, this pediatric department of nephrology, and Suman will tell you, we are doing regularly this protocol biopsies.
Oh, I see. Okay.
Yeah,
great.
We have a lot of experience of protocol biopsies, and many times we get the rejection, pick up the rejection in that biopsies. I think that helps us to prevent and this treatment of early treatment of this patient.
Fantastic. They're keeping you busy, Dr. Kanodia.
Yeah.
Madam, one thing I would like to ask, whether you use tocilizumab alone or in addition to plasma exchange?
That's a very good question, Dr. Was that Dr. Shah? Sorry, doesn't show.
Dr. Gera.
Oh, Dr. Gera, thank you. We use plasmapheresis as the initial standard of care. So if we have a lot of very strong antibodies, we will do plasmapheresis, IVIG, and rituximab. And then if after doing that, we see that either their biomarkers are still elevated or their creatinine is still elevated, and we do a biopsy and we continue to see ongoing AMR, these patients are started on monthly tocilizumab. So before starting them on monthly tocilizumab, we give a dose of IVIG, and then every month we give them tocilizumab. We don't redo the plasmapheresis at that time. So these patients have all got plasmapheresis up front. First.
At the same time, you had been telling that earlier use of tocilizumab rewards more than later use. So is it not better to use tocilizumab in all patients in the beginning also?
Very, very good question. So we've been talking about that and toying with that idea, but I think there is something to be said about using rituximab, because rituximab is a very strong B-cell monoclonal antibody and it prevents excessive formation of antibodies. So you would want to use rituximab somewhere in your armamentarium. And there are a lot of patients, in fact, about 20 to 25% of the patients, it's just enough to use plasmapheresis, IVIG, and rituximab. They do fine. These are the patients who you've detected early on and they do completely fine. It's the patients who don't respond to that standard of care therapy that go on to get monthly tocilizumab. I think the problem with using tocilizumab upfront is that you kind of don't know where to stop because you have to keep going because, so we use the standard of care first and then continue them with monthly tocilizumab.
But one thing that rituximab using is more scaring rather than freely using tocilizumab to risk the life of the patient. If such option is available, we reduce the rituximab and can we add the tocilizumab in all of the patients?
Very good thought. I think these need to all be proven in clinical trials, Dr. Gera. If there's a clinical trial that comes about with the start of tocilizumab itself, that will be wonderful. We can see what difference it makes compared to standard of care therapy. Yeah.
Thank you, madam.
Thank you.
So we do protocol biopsies at 6 months and 1 year. And if the patient develops de novo DSA and still the creatinine is normal.
Yeah.
So we get a good number of subclinical rejections that we treat. And that we have observed, though we have not analyzed the data. But that we have observed that if we treat that subclinical rejection, subsequent protocol biopsies come out quite normal.
Correct.
And the creatinine gets stabilized. So to say that treatment of subclinical rejection also helps. And the other reason of doing all this is that recently our rate of development of de novo donor-specific antibody in patients who are not pre-sensitized also is quite high. So that's why we keep doing protocol biopsies, particularly when they develop a de novo DSA and the creatinine is normal. And if along with the development of DSA, if they have rejection, then we treat it as a full-blown rejection.
Correct. Yeah, that is the way to go. And like I was saying, early recognition and treatment really helps. And that's why, if you use the standard of care protocol, we see that about 20 to 25% of patients do extremely well. But these are the patients who the rejection has been recognized very early. They don't have an increase in serum creatinine. They don't have proteinuria. And so, they do, extremely well. So the patients whom we don't diagnose early. So, if you're doing protocol biopsies, how long do you do it for? Like, I know you do it at 6 months and 1 year. What about there's a patient who's 5 years out of transplant? Do you still continue to do protocol biopsies?
Right now, we have not reached that stage yet, but we have protocolized, like every year we will be doing the protocol biopsies. Yeah,
I think you will like the use of biomarkers, the cell-free DNA and stuff, because they will stratify these patients based on risk. So if you have a patient, in whom you do cell-free DNA every 3 months, increase in cell-free DNA, from their baseline values indicates that there's some injury to the allograft. And those are the patients whom you can do a biopsy to make the diagnosis of rejection. But let's just say you have a patient who's been stable and all that, no increase in creatinine, and you do a biomarker and it's extremely low. The value of doing a biopsy in these patients is much less because they are less likely to have rejection. So you can target the patients in whom you want to do a biopsy, even though they are far out of transplant, based on certain parameters, like their some kind of a biomarker value and development of DSAs, those kind of things will help you delineate which are the patients who need a biopsy versus not.
So what do you do when the patient develops a de novo DSA, but the creatinine is normal?
We've been doing a biopsy because, we don't know whether this DSA is pathogenic versus not. So these patients end up getting a biopsy. But now, if they have a de novo DSA, their creatinine is normal, and their cell-free DNA is very low, we almost never do a biopsy because we feel that the yield for rejection is actually pretty low if their cell-free DNA level is very low. So we have a few patients who have, mild to moderate de novo DSAs. A lot of them, it's like class 1 DSAs. And so you're not sure as to whether these class 1 DSAs are actually, injurious to the graft or not. And so if you do a biomarker, and if the biomarker is just very, very quiet and low, then it's likely that that particular DSA is not causing any injury to the graft. Does that make sense?
Yeah. Do you do complement fixing DSAs?
No, we don't, because what we found is that if you have very strong DSAs, you end up doing a biopsy. And when you end up doing a biopsy, and if there's AMR, obviously these DSAs are complement fixing. And even if they're not complement fixing, they are causing injury to the graft. Remember, right. I showed you that slide where you can have complement fixing, no complement fixing, and antibody-dependent cell type toxicity. So not all the injury is, complement fixing. So if you find injury, whether this complement fixing or not, it really doesn't matter.
And when do you do the AT1R receptor antibodies?
The AT1R story is it's a very controversial story. In fact, when I came back from the American Transplant Congress, like I said 2 days ago, there were pros and cons of, there was actually a debate, pros and cons of doing AT1R. What we found in our center is that if you have isolated AT1R with no donor-specific antibodies, they're less likely to cause problems in the allograft. But if you have donor-specific antibodies along with AT1R, they're much more likely to cause problems. So my recommendation is, if you have strong donor-specific antibodies, there may not be a need to do AT1R because you already have a reason for why you have antibody-mediated rejection. But on the flip side, if you have antibody-mediated rejection on the graft and no DSAs at all, which can happen, then you look for non-HLA antibodies. And I think that's money well spent.
Right.
Make sense?
Yeah.
Yeah.
Dr. Priyas is asking.
Anshuman,
Ji,
Yeah.
sir, boliye,
I
sir.
have one query. While using Allosure, what kind of injuries other than rejection we can find out in the allograft?
Fantastic, sir. Fantastic question.
Yeah.
So, and what we have found is, Allosure can also tell you about T-cell mediated rejection, even though it's not very great in picking up like the early 1A, BAMF 1A T-cell mediated rejection. But you can also have, I don't want to say false positive, but if you have a patient who has like pyelonephritis, for example, you can have a very high cell-free DNA level because it is injury to the graft. So you cannot interpret a high, cell-free DNA level in the presence of pyelonephritis, but it will not give you a high value in terms of like patients who have CNI toxicity, patients who have ATN. It doesn't give you a high value then. It gives you a high value when there is a lot of endothelial injury. So pyelonephritis, T-cell mediated rejection and antibody mediated rejection are the top ones where you actually get it. And the other place that you get it is BK nephropathy because it's injury to the graft. So any kind of injury actually will give rise to that. So you have to be careful when you interpret the results. And that's why you end up doing a biopsy to actually see what's going on. But, if you have pyelonephritis, then do not do a cell-free DNA level.
Thanks, ma'am. Thanks.
So Dr. Priyas is asking, how many weeks or months later shall we do renal biopsy post AMR treatment? If patient responds well, to look for residual AMR.
I think the question is, what do you mean by if the patient responds well? I'm taking it that the creatinine, sort of comes back to normal if the creatinine was elevated, right? In that case, we actually do not do a biopsy. So, if we have given plasmapheresis IVIG rituximab, the creatinine was a little high, it came down to its baseline, and the donor-specific antibodies are looking much better than when you started off with, there may not be a need to do a post-AMR treatment biopsy. But in a lot of instances, we end up doing it because their DSAs are still pretty high after a plasmapheresis IVIG rituximab. Their creatinines are still high after that initial treatment. So we end up doing a biopsy, and we usually wait for 3 months after treatment to do a biopsy to just make sure that, the treatment has taken effect and things are actually at, whatever baseline we want to see it in order to look for AMR again. Does that answer your question, Dr. Thambi?
Yeah. So
Thank you.
we'll move forward for the case discussion now. I will ask Dr. Sehnaz and Dr. Lovelace. Dr. Sehnaz is Assistant Professor Pediatric Nephrology and Dr. Lovelace is Associate Professor in Pathology to proceed for the case discussion.
Thank you, sir. Good evening to everyone from Ahmedabad. I'll begin with the case. A 14-year-old male child who underwent kidney transplantation on the 30th of August, 2021. A brief look at his pre-transplant course. He presented at 9 years of age with refractory anemia and ended up receiving 5 units of blood transfusions over a short span of 2 years. Unfortunately, we had a classic case of tunnel vision causing missed diagnosis for almost 2 years, where symptomatology in the form of diminished night vision, polyuria, polydipsia, growth failure, and stage 2 hypertension were totally out of focus. Even family history for the elder sibling who was diagnosed with atypical retinitis pigmentosa could not serve as a clincher unless a medical trainee relative identified that an important investigation for refractory anemia had been missed. Lo and behold, the creatinine, which was done at his behest, was 9 milligrams per deciliter. Obviously, the child was referred to us And in November 2019, when he came to us, we did a thorough history and clinical examination, which confirmed his underlying chronic status. Lab workup again confirmed a state of solute overload with hyperkalemia, uremia, and metabolic acidosis, CKD-MBD markers deranged. And radiologically, we identified that the child had small volume kidneys. With this background, we concluded a preliminary diagnosis as nephronophthisis along with retinitis pigmentosa, fitting into senior Loken syndrome phenotype. With a very strong family history of the elder sibling pursuing a similar clinical course, we went ahead and did genetic analysis for the family. The whole genome sequencing was done for the elder sibling, which was followed by targeted sequencing for index case. Very interestingly, the phenotype, though senior Loken syndrome, revealed an underlying genetic mutation, which was documented with Joubert syndrome. So retrospectively, although the siblings did not have any CNS or cerebellar manifestations, we went ahead and did a CNS examination, and neuroimaging did not show any neurological involvement. Further course, since the child had presented to us in kidney failure, RRT was initiated. Maintenance hemodialysis thrice per week was started since November 2019 via the left brachiocephalic AV fistula, and luckily for him, he did not have any vascular access related issues. And for a duration of 1 year, 10 months until he got a transplant, this was the access which served him well. During this course, blood transfusion, once a unit of irradiated PCV had to be given inevitably, although we are very stringent as far as sensitizing events are concerned. He had one severe infection, septic arthritis of the left knee joint, which was appropriately and adequately treated with complete recovery. The other significant comorbidity was hypertension, which was managed and well controlled with 4 antihypertensive drugs. The child did not have any living related donors, and also since 2 siblings from the same family were in need for an organ, we were more inclined to register them for cadaveric transplantation, and hence they were registered under SOTO in March 2020. So pre-transplant registration workup, sensitizing events identified were blood transfusions. 6 units of blood transfusions had been received in a short span of 3 years. One significant infection in the form of septic arthritis. Immunological workup, HLA typing was done apart from the conventional A, B, and DR loci as per our institutional facilities and immunological protocol. The other loci which were also typed are the DQ and the C loci, and detailed serological as well as molecular typing is done. At the outset, pre-registration in February 2020, a panel reactive antibody suggested class 1 and class 2 positivity, 20% and 27% respectively. This coincided with the infection episode, so some amount of triggered immunogenicity did play a role here. The screening multi-antigen bead assay, however, did not show any positive class 1, class 2, MIC-A, all were reported as negative. Subsequently, 1 year after, in February 2021, we repeated the PRA, which was negative at this point of time. However, the screening bead assay was followed up by the single antigen bead assay in view of the previous sensitizing events. And this revealed a class 2 positivity, anti-HLA antibody. 2 of them were identified against class 2, DQ-A1 and DQ-B1, maximum MFI being 2058. Our institutional cutoff is 1000 MFIs. Ultimately, he finally got an organ offered, favorable organ from a 19-year-old male who had succumbed to a head injury due to road traffic accident without any comorbidities and a favorable creatinine of 0.8 milligrams per deciliter. HLA mismatch was 4/6. Cross-match was acceptable with LCM 15% and AHG 17%, our cutoff being 20, and the flow cross-match was negative. With a cold ischemia time of 19 hours, he underwent an open right iliac fossa transplant with stringently monitored and optimized hemodynamic parameters intraoperatively. There was no requirement of any blood transfusion or colloids during the course intraoperative, and he did come out with an on-table decent urine output of 300 ml. Immunosuppression history. For his weight of 31 kilos and height of 145 centimeters, he was planned induction with thymoglobulin, received 3.3 milligrams per kg in divided doses on day of transplant, day 1 and day 2. Methylprednisolone, 10 milligrams per kg per dose, followed by 10 and 5, 10 plus 10 plus 5 on day 0, 1 and 2. This was followed up by maintenance immunosuppression, CNI based. Tacrolimus at a dose of 0.07 milligrams per kg per day at the onset, followed by close monitoring of the trough tacro levels, and accordingly doses were titrated. MMF was initiated at a dose of 600 milligrams per meter square, day 0 onwards, and gradually increased to 900 to 1000 milligrams per meter square by the end of the first month. So this is a timeline representing his first month course post-transplant. The vertical axis shows the creatinine values, and the horizontal axis is the timeline. The blue line traces the creatinine. Pre-transplant creatinine was 4.5, and a very promising fall in creatinine observed till day 5 when he was discharged. At this point of time, his creatinine was 0.8 milligrams per deciliter, good graft function with a very good urine output. And on day 5, when he was discharged, his trough tacro level was 12.9, a little on the higher side for our target values. And therefore, we came down on his tacro level, on his tacro dose from 0.07 milligrams per kg per day to 0.065 milligrams per kg per day. Following that, he was discharged and was under close monitoring with us when on day 15, he presented with slightly creeping up SGPT levels. The red line traces the SGPT values. This coincided with the MMF doses increased to 900 milligrams per meter square. Having ruled out other infective causes to explain the transaminitis, we concluded it to be drug-induced. And under close monitoring, we continued with the same drug dosages. And luckily for us, a downward trend was established by the day 30 post-transplant without any active intervention. At this point of time, we had come down on his steroid dosages to 22.5 milligrams per day from 1 milligram per kg per day, which was the initial dose. MMF was continued in the same dose, and tacro level, according to the trough monitorings, was 0.06 milligrams per kg per day. As per our unit protocol, on day 30, we screen all our post-transplant patients for emergence of de novo DSA, and this screen was negative. The viral markers are also done as a part of the unit protocol, which was also negative. The further 6-month transplant course is depicted in this timeline, and the red line traces the creatinine, which was fairly stable between 0.4 to 0.5 until 3 months post-transplant with proper follow-up and ensuring good compliance. As per our unit protocol, again, a 3-monthly screening was done, which revealed emergence of de novo DSA at this point in time, DQA10101, with 3,446 MFI appeared, while the viral screen was normal. It was negative for the viral markers. And this prompted us to go ahead and do a biopsy, although the creatinine was normal. So I'd like Dr. Lavlesh Nigam, Associate Professor in Nephropathology, to take over and discuss the biopsy findings with us.
Thank you, Dr. Shehnaz. Good evening to everyone. So this is Dr. Lavlesh from Department of Pathology. As Dr. Shehnaz said, we received a biopsy, a single core one, and we can very well see that there are a fair number of globuli in the biopsy, which we received. Next. So what we can see in this biopsy are glomuli and the tubules. In this past stain section, we can see 4 glomuli here. And when we take a closer view of the glomuli, we can see that these capillary lumina in the glomuli are occluded by the swollen endothelial cells. And few of the capillary loops also show presence of inflammatory cells or WBCs in the lumina. So this is again depicted in this hyper view. Along with that, we can also see there's a additional component of acute tubular injury, where we can see tubules showing flattening of the tubular epithelial cells. A few of tubules also showing cytoplasmic degenerative changes. In the next slide, So we can, when we take a closer view, we can see these peritubular capillaries, which are present in between the tubules. And these capillaries show presence of leukocytes. So we can see neutrophil, and we can count 1, 2, 3, 4, 5, 6. Similarly, we can see PTC, dilated PTC here. We can see PTC here. And when we did a C4D stain, these PTCs stained positive. So we can see a nice granular deposition of C4D along the peritubular capillary membranes, and we can also see the leukocytes in this. Next. So what we concluded in our report was we had 11 glomeruli with 2 blood vessels. As we could appreciate glomerulitis in all the glomeruli which were sampled, so we gave a score of G3. Tubulitis was not seen, so we scored it as 0. Interstitial inflammation was minimal, less than 25%, so we reported it as I1 and TI1. Peritubular capillaritis score was PTC2. Though as diffuse C4D positivity was seen, so we scored it at C4D3. Other BAM scores of chronicity were 0. There was no arterial hydronosis or intimal arteritis. So what we diagnosed it as was morphological features suggestive of active antibody-mediated rejection. And we also asked the clinician to correlate the above findings with the serum DSA levels. Thank you. Dr. Shehnaz?
So with this report suggestive of active antibody-mediated rejection, we did go ahead and initiate treatment, starting with 3 methylprednisolone pulses at 5 milligrams per kg. 5 plasma exchange sessions were done, followed by IVIG. And we optimized the triple immunosuppression, targeting higher TAC trough levels. And in accordance, the dose was increased to 0.07 milligram per kg per day. Plan was to further follow this up with the dose of Ritux 15 days after the IVIG dose. But unfortunately, for us, the child was diagnosed to be COVID-19 positive, incidentally diagnosed because of COVID RT-PCR screening as per the hospital policy at that point of time. He was asymptomatic. But since RT-PCR was positive, we did not administer Ritux at this point of time and waited. Ended up waiting for a good 2 weeks because the RT-PCR persisted so long. And almost 1 month after the plasma exchange sessions, he ended up receiving his dose of Ritux, 375 milligrams per meter square. And for whatsoever benefit, we initially gave him 3 sessions of plasma exchange, followed by Ritux at this point in time. Again, tacrolimus level was monitored throughout on weekly basis during these therapy period. We were struggling with low trough levels and ended up progressively increasing the tacrolimus dose to 0.09 milligram per kg per day. By this point, the creatinine, which was seemingly benign and normal range 0.4, 0.5, started to slowly creep up. 4.5, 5 months post-transplant, by the time we ended up treating him with Ritux, his creatinine was almost 0.83 milligrams, significantly higher from his nadir and baseline creatinine. Other interesting development at this point was the counts were fairly normal till 4 months post-transplant, but after administration of Ritux, they started falling. We had a low count of almost 2,000 millimeters, 2,000 cells per millimeter cube, and we ruled out infection and ultimately attributed it to be drug-induced. Initially, valganciclovir was stopped, and since it did not yield a significant rise in the counts, MMF dose was reduced from 1,000 milligrams per meter square to 833 milligrams per meter square. In spite of these changes, and we waited for Ritux to show some effect, but the creatinine continued to creep up to 1 milligrams per deciliter. By 6 months post-transplant and 1 month post-Ritux, we repeated the de novo DSA screening. A single antigen bead assay was done, and contrary to our expectations and in accordance with the rise in creatinine, we ended up in a soup. Despite adequate treatment, to the best of our abilities, DQ class 2 de novo DSA, newer DSAs started emerging by this point in time. The viral screen was negative. So 6 to 7 months post-transplant, the issues that were bugging us were rising creatinine and de novo DSA emergence despite MPS pulses, Plex, IVIG, Ritux, textbook treatment. So what were we dealing with? Whether this could be labeled as redux refractory AMR. Were we really low on the immunosuppression because of low trough levels throughout, in spite of ensuring adequate drug compliance? Could this be attributed to the significant gain in the weight of the child? Pre-transplant weight was 30 kilos, and almost 6 months down the line, he had gained 12 kgs from his baseline, which could have caused increased volume of distribution and thereby increased requirements of tacro? Or were we dealing with a situation where he had a rapid metabolism, or was it issues with the drug formulation? Other problem was with leukopenia, which inhibited us from optimizing the MMF levels as well. So in fact, we had to come down on the doses of mycophenolate mofetil. And all this actually hinted that he was undersuppressed and mounting more and more immunological response in terms of de novo DSA emergencies. This prompted us to go ahead with the second biopsy, which was done 6 months post-transplant. Dr. Lovelace, kindly take over.
Thank you, Dr. Shanaz. So we received a single core of biopsy, and now this time when we received the biopsy, we could also appreciate areas of chronicity. The number of glomeruli were adequate, and we here in this scanner view, we can see these glomeruli, and of course we can see these blue dots, which are the WBCs or the lymphocytes, and then we can see these tubules, the tubules also showing dilatation, suggestive of injury. This is a corresponding GT stain, and we can see, we can appreciate focal areas of fibrosis in the same. Next slide. This is HE stain section. Here we can see the sampled artery. The artery doesn't show any signs of immunological injury. Here we can see the glomerulus, and again we can see these blue dots or the leukocytes which are present. Similarly, another field of the biopsy where we can see this infiltration, we can also see the tubules, and we can see glomeruli showing again blue dots. Next slide. When we look into the higher magnification, we can see that these glomeruli are infiltrated by leukocytes that suffice for the to call it as glomerulitis. Along with that, there is swelling of these are also occluded by the swollen endothelial cells. And as per the BAM guideline, swollen endothelial cells with leukocytes denote glomerulitis. This is the area of chronicity which we are seeing here. Then we have these tubules, and we can see these peritubular capillaries which are dilated. The next section. So again, here what we see are the tubules and the peritubular capillaries. The tubules are dilated. Okay, we can also see these flapped epithelial cells showing features of ATN, and then we have these peritubular capillaries, and we can count 1, 2, 3, 4, 1, 2, 3, 4. So there is presence of leukocytes again here in this field 1, 2, 3, 4, 5, 6. So a fair number of leukocytes are seen in these dilated PPCs, and then we did a C4D stain. Also, a few of the tubules showed tubulitis. We can see lymphocytes infiltrating the tubules. Now, again, this is the PTCs where we can see the presence of leukocytes, and when stained with C4D, they showed again granular positivity. So, to summarize up the findings of the biopsy, we had a single core of renal tissue which had nearly 12 glomeruli with 2 blood vessels. Glomerulitis was a little less than last time. It was of G2. We had tubulitis of T1. Infiltration was not much, I1, TI1. Peritubular capillaritis was scored as 2. C4D was also scored as 2, less than the last biopsy. And the other biopsy, other BAM scores were CG0. There was no duplication because of the presence of fibrosis, which we saw in the interstitium and tubular atrophy. Though it was less than 25%, it was present and was scored as CT1 and CI1, IFTA grade 1 BAM, and we gave a diagnosis of morphological features suggestive of active anti-mediated rejection again. Thank you.
So with the second biopsy suggestive of active antibody-mediated rejection with progressive rise in creatinine to more than 1, the treatment which we initiated is IVIG given in a dose of 2 grams per kg. Triple immunosuppression was optimized. TAC levels, now at this point, the tacrose trough levels started rising significantly from our target value. 9.93 was the value documented 6 months post-transplant. And with creatinine on the higher side, we did come down on the dose of tacrolimus. It was reduced from 0.09 to 0.085 milligrams per kg per day. MMF, we continued in the same dose since we were still struggling with leukopenia. All the WBC counts serially monitored were less than 4,000. 8 months post-transplant in May 2022, creatinine still lingering 1.05 milligrams per deciliter. Tacro levels, we are monitoring closely. Now, surprisingly on the higher side, 8.63. Again, TAC dose reduced to 0.08 from 0.085. MMF, same dose continued. What do we do next? So, Madam, my first question for you is, what is pre-transplant immunological risk stratification? Was there any role of desensitization pre-transplant in our case? Although your views on that, ma'am?
Yeah, so I mean, all these transplant cases bring our knowledge to a pause. It's like, do as much as you can and kind of hope for the best situation. And sometimes it's not always the situation that is the best. But my questions that I wrote down here to ask you is that, did you do any desensitization prior to transplant? And, in this case, the sort of, there was some antibodies which later on became negative, when you were about to transplant him. And I think that was the reason for you sort of not to consider any desensitization. However, what it was telling me is that this child is at high risk for formation of antibodies, because he's shown you before that he can form a lot of antibodies. Lo and behold, those antibodies got better, but he definitely was at risk for forming antibodies. And in these instances, we would have at least done IVIG and Ritux going into transplant. And one of the reasons is because, and Anshuman and I have talked about this, I really like Ritux as an induction agent as well, because it really prevents the formation of these DSAs, at least for the first sort of 6 months while the rituximab lasts, and while you're adjusting all the immunosuppression, like TAC levels sometimes can be really low, MMF because of, decrease in your white cell count or intolerance or whatever, you're adjusting the MMF levels. So your MMF may not be adequate. We don't monitor their levels over there. So these are the kind of patients who are at high risk for developing de novo DSAs, because they've shown you before that they can form antibodies. And these are the patients in whom it won't hurt to start off with a dose of IVIG and rituximab before they form any of these antibodies. That's what it is, in my opinion. Really, we have a very low threshold to give rituximab pre-transplant to these patients who've shown us that they can make antibodies. Unless they have a clean slate, they get rituximab and IVIG.
So my second question was any modifications in the induction immunosuppression from what we used. So I guess, ma'am, you have answered that you would use Ritux.
I would give rituximab.
Yeah, ma'am.
Yeah.
Okay. Ma'am, in your opinion, did we do justice in treating the first episode of antibody-mediated rejection? How would you manage a situation like this, middle of the treatment protocol? If some infection episode appears, how would you go about things further?
You are, from what we know, you are absolutely right in the way you've treated your AMR. Again, from what we know. I don't think that the drugs that we have right now adequately address AMR. And I really think that, there are, I'm sure, more drugs in the pipeline and clinical trials that will help us address it. But at least at this point in time, from what we know, you've done the right thing. And also, obviously COVID-19 is always, they can go downhill in terms of AKI and stuff. So you have to be cautious. And it was just a bummer that, at the time that you wanted to give rituximab, you also had COVID-19. And you don't know whether infection actually precluded, made him get more antibodies because, he was exposed to infection. In fact, there were a number of papers at the American Transplant Congress showing that COVID-19 infection predisposes you to have DSA formation. Like a lot of infections can predispose you to have DSA formation. So personally, I think you did your best in the way you treated him with plasmapheresis IVIG. You could not give rituximab at the time that it needed to be given because of the COVID-19 infection, and it was very appropriate to hold the rituximab for at least 2 weeks. But I think by the time you gave it, and also because of COVID, there was an increased risk for developing more DSAs, and that's what happened. This is kind of the cases that we see, and I'm just going to your next question. This is what we would call refractory AMR, because obviously after B-cell therapies, you still have AMR on biopsy, even though maybe it is like slightly better. I think that since you've not reached the stage of chronicity yet, you are still in luck, and you may be able to prevent further decline in your serum creatinine, in your GFR. And in our books, we would start treatment with, we'd give them a dose of IVIG and start monthly tocilizumab for this kind of patient. And just hope that the creatinine stabilizes. Yes.
Ma'am, for how long do we need to continue the monthly tocilizumab doses?
Very good question. Yeah, very good question. Some of these patients require only 6 months of monthly tocilizumab and do fairly well with just 6 months of monthly tocilizumab. I feel like maybe this would be one of the kids who would do well with just 6 months of monthly tocilizumab, because this is just still very active. There is no the CG score is 0, so there's no chronicity. So I feel like this would be the kind of patient that might respond to monthly tocilizumab for maybe 6 months. I feel like you'll also end up doing a biopsy maybe after 6 months of tocilizumab to see how much better you've gotten. And if there's still ongoing AMR, we would continue the tocilizumab. And your last question, yeah, go ahead.
Madam, is there any role for monitoring IL-6 levels on tocilizumab?
We don't do it. We don't, it's very hard to get IL-6 levels, first of all. There was a study that was done looking at IL-6 levels in the biopsy, and that was done as a research protocol. And they found that in active AMR, there was a lot of IL-6 on the biopsy specimen itself, but we don't have ongoing results to show how the IL-6 levels fluctuate with treatment with tocilizumab. Okay. But something that, if you consider doing and it's easy for you to do, would be a nice, research proposition to see how it changes. In regards to the last question, go ahead.
Madam, I also want to know about the leukopenia. What is your comment on that, madam? In a situation like this, when we clearly know that there is nothing else sinister sitting underneath, is it okay to administer GCSF at intervals and keep the immunosuppression still optimized? Or how would you go about a situation like this?
Yeah. No, actually, GCSF is very, very useful. For the last 4 or 5 years, till the last 4 or 5 years, even we were not, using GCSF as routinely, and we would reduce immunosuppression. And we saw a lot of our patients developing de novo DSAs, which is, it's terrible. Once you develop DSAs, it's like going down this, rabbit hole where there's no appropriate treatment to actually reverse it fully. So we've taken the stance of using GCSF early on with these patients. And like you rightly said, I think the leukopenia is a combination of MMF and perhaps the rituximab. I'm sure there was some, hypogamma involved as well with the use of rituximab. So I would use GCSF early on and try to keep your MMF levels at least, the 800 that you were targeting, 800 milligrams per meter squared per day. Yeah, so definitely use GCSF. The reasons in the past why we were hesitant to use GCSF was there was a very remote paper that showed that use of GCSF revved up a lot of activated T cells, and there was a risk of graft rejection, but we have not seen it in our any of our recent cohorts. In fact, one of the papers that we had published looking at use of GCSF in thymoglobulin and alemtuzumab induction patients did not show an increased risk of development of either DSAs or increased risk of rejection. So it's pretty safe to use GCSF. Yeah.
What is the effect of tocilizumab on leukopenia?
We've seen in certain patients that it definitely can cause, sort of almost like a pancytopenia with lowering of your white cell counts, lowering of your hematocrit, and also, a decrease in your platelets. A lot of our patients who are on tocilizumab, the adult group at our center routinely decreases CellCept dosage by 1/3 when they use tocilizumab. But we have not taken that stance because not all patients develop anemia on tocilizumab, and not all patients develop leukopenia on tocilizumab. So we have continued the same dose of CellCept with the use of tocilizumab, and in patients who develop leukopenia, we've kind of, adjusted the MMF to a certain extent, but also used GCSF in those patients.
Just early this week, when our child came for follow-up, 2 hindrances in administering tocilizumab is that his counts are still like 3,000, although the ANCs are more than 1,500. So I guess GCSF administration could help us tide over that.
Yeah.
So the other issue is, madam, prior to tocilizumab, the infection workup that we did, we also administered him a dose of Montu. And that has turned out to be positive, suggesting some underlying TB infection. So how do we go about further? Because case reports suggest,
yeah, I was going to ask about this possibility of reactivation of latent tuberculosis.
Yeah.
Because in US you might not see tuberculosis that much. But I guess in India, almost all are exposed.
Your world. Yeah, exactly. I was just going to say tuberculosis is your world, nobody's, I would say anybody in the US is an expert compared to all of you here there in India, because you see it and you breathe it, smell it all the time. So I think that if you're really suspicious that this is TB, sort of all bets are off in terms of increasing immunosuppression. Definitely, of course, do not even consider increasing immunosuppression. I think you should get the help of ID in terms of how you would manage a manto-positive patient and go for it. And I think also that, I don't believe tocilizumab can worsen TB. It's a very mild immunosuppressive medication. In fact, like Dr. Shah had asked about infectious complications, we see very few infectious complications in these patients, but before starting tocilizumab, I would definitely speak with ID in terms of how you would treat TB while sort of keeping the immunosuppression, fairly well tolerated. I think more IVIG will definitely help here because, IVIG, as you know, is a immunomodulator. It won't increase the risk of any kind of infections. And in fact, you might get passive antibodies in order to control the infection. So more use of IVIG here than not would be my stance treating this patient. Tough one.
Ma'am, please go ahead and answer the final question.
Yes. So, I get this question all the time. I think for me, in terms of side effects profile, I like tocilizumab because we've used it. We've used it, like I said, for over 8 years now. And the side effect profile is just, so comparable compared to most other drugs. And bortezomib, we've used it too, but the side effects are so, they're kind of so much worse. And the side effects, some of the side effects are not reversible, like peripheral neuropathy and stuff are not reversible. And so that bothers me. And then bortezomib can cause complete resolution of DNA, but DSA, but it's not long lasting. You can start to have, a rebound DSA once the effect of bortezomib is gone. And if you consider a second cycle of bortezomib, the side effect increases quite a bit. So we're not totally sold on bortezomib because of its side effect profile. However, I'm telling you, there's a clinical trial that's coming about with the use of bortezomib and belatacept in the treatment of AMR. So let's stay tuned and see what the results of these studies show. In terms of eculizumab, I think eculizumab is useful when you have initial, within 30 days of transplant, you have AMR. Those we definitely know are because of the preformed DSAs and their, and complement injury. And it's at that time that I would consider using eculizumab, but I'm not quite sure if I'd use eculizumab in someone this far out, in whom you don't know how much of it is complement dependent versus not. But having said that, though, if you have, we also showed some improvement in the AMR, right? The other thing is, once you start using eculizumab, I'm not sure how, when you would kind of stop it in terms, or you would use just one-time dose. And of course, as you all know, with eculizumab, you definitely need to, make sure that the meningitis issue is addressed because they're at very high risk for Neisseria meningitis. So I would start with tocilizumab, and if the serum creatinine is stabilizing, I would continue with the monthly tocilizumab. But if you see very robust ongoing rejection, then I would, consider using eculizumab at that point, and and see what happens. Yeah, I think that you would be able to stabilize your renal function, serum creatinine with tocilizumab. Actually, I think this is early rejection. There's no evidence of chronicity, and I think you can get by with tocilizumab with lesser side effects compared to other drugs.
Thank you, ma'am. I'd like to finish my presentation with this picture. It's like the flag bearer image of promoting organ donation. The two siblings who are here pictured with the donor's parents. So very humbling and very inspiring photograph. Thank you.
Very, 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 very. Yes, everything that we do is really very gratifying. It's a tough job, but you all are doing a fantastic job, really. And looks like you have an amazing group over there as well. So keep it going.
Thank you. Dr. Kinnari, would you like to ask some questions?
Yes. Good evening, madam.
Good evening.
Good morning,
Kinnari.
good morning to you, madam.
What is
madam,
it?
I just wanted to ask you regarding use of immunoadsorption in such refractory cases. So, like we have done some 5+3 8 plasma exchange, and somehow we are now able to do it in our institute. So, should we give a trial of immunoadsorption, or there is no such role in refractory ABMR?
I think very few centers do immunoadsorption. They end up doing plasmapheresis itself. So you're talking about immunoadsorption is different from plasmapheresis, correct, Kinnari?
Yeah. Yes, madam.
Yeah. So truthfully, I've not seen papers, at least from here in the US, looking at immunoadsorption for these patients, because I believe that I think plasmapheresis does pretty much the same job. But it's if it's a very easy to get procedure, there is no harm in trying and seeing what happens to donor specific antibodies.
Okay. Okay.
Any other questions? There are no audience questions also. So can we wind up now?
It's so late for you all, and
it's okay.
Past all your dinner time.
So I request Dr. Kinnari to wind up.
So thank you so much, madam, for always being there for us, for your constant guidance and throwing light to such difficult cases. And as you said that at the end of the day, it is worth taking so much stress, because when we see such pictures, you forget all that exhaustion, stress, and brainstorming exercises. And thank you so much, Dr. Gera sir, Pankaj Shah sir, and Kamal Kanodia sir, for being there and being part of our webinar. And thank you so much, Dr. Lovelace, for wonderful presentation. Thank you.
Thanks a lot.
Thank you, ma'am.
Thank you, madam. And we wind up with this. Thank you.
Thank you, everyone.
Thanks. Thank you.
See you soon, madam.